I think, is it the second? Is it the second ecosystem event of the year so far? But one of many. So if you're new, welcome. If you've been before, welcome back. So just to introduce myself, I'm Laura Rooney. I'm the Director of Corporate Strategy at an organisation called Health Innovation Manchester. And I'll tell you a bit more about Health Innovation Manchester in a few moments. I'll be hosting the first half of today's session. And then I'll be handing over to my colleague, Peter Richards, who will take you through the second half of the session with some of our fantastic speakers. So the theme of today's session is how the pandemic sparked innovation and we were able to use it as a catalyst to drive research and innovation across the Greater Manchester City region. And just a bit of housekeeping to make sure it's a fun and active event for us all. So the beauty of these events is it's a network of bringing people together to share learning and insight. So please do post questions, comments, queries, reflections in the chat function. There will be time to pose questions to speakers after each session as well. But we'll be keeping an eye on the chat to pull out some key reflections for our speakers. So that would be fantastic. I think Andy may have already put in the chat, but if you could just say hello at the top of the meeting in the chat by introducing yourself and where you're from, and also when if you're coming on to ask a question, do the same. And we've got a hashtag there. Please promote any thoughts or insights from today's session using the hashtag there. And just to note, today's event is being recorded. Okay, so we've got a great agenda for this afternoon. I will be taking you through what we've done from a digital transformation perspective in health and care, particularly in response to the pandemic, but also what's to come next. And then that will be followed by a short update from Andy about what's been going on in the across the Alliance network. Then we'll be joined by Jack Williams, who's a client director at Better, looking at digital platform strategies. And then Professor John Ainsworth from the University of Manchester will take us through the eLab Health Data Science Workbench. Sounds very exciting, John. Then Ian Hall will take us through social care data analysis and advice. And then we'll be joined by Steve Boyle, who's Programme Director at Health Innovation Manchester, who'll be focusing particularly on what we're doing in digital primary care. And that's kind of been accelerated as a result of the pandemic as well. So really varied topics. And I'm sure there'll be lots of sort of common threads of how this all comes together through the health and care system as well as we go forward. Okay, we best get on with the agenda to stick to time. So I think I've got about 10 minutes or so, but Peter, just give me a nod if I lose track of time, which you can easily do when you're sharing screen. Health Innovation Manchester is an organisation that works across the Manchester City region. We are partly funded by the NHS nationally and also locally in the Greater Manchester system. We also work with industry and academia, and our job really is to find new innovation, accelerate it into practice to benefit citizens and also deliver economic benefits for the city region. That's probably the most simple explanation of what we do at Health Innovation Manchester. We're in our 4th year now of operation, and it's fair to say we've evolved our work and our portfolio during that time. And the pandemic itself was actually proved to be a real opportunity for harnessing innovation and getting traction in the system to deploy innovation at scale. So I'll talk a little bit more about that as we go through. So, I mean, where to start? This slide feels a bit like a trip down memory lane now, since we are, best part of 2 years into the sort of pandemic response. So when the pandemic first kind of kicked off in that March, we actively paused a lot of our innovation activity that was in flight at that time and worked with the GM Health and Care partners to understand their major issues and their major priorities, and we essentially pivoted our focus to directly contribute to the pandemic response, working with, at that point, the NHS kind of established gold command and control cells, where we were taking national guidance and enacting that through region, and we felt that our response was best placed in digital innovation and transformation. I mean, just for background as well, there was also a sort of rapid research response that mirrored this. And there's a series of projects and programmes here that we mobilised in partnership with Greater Manchester Health and Care Partners. So we'll talk about digital primary care in some detail later on in the session today. I'll also talk to you a bit more about the GM Care Record as part of my session. I guess a couple of other things to point out, and particularly are going to be big news for the future next stage of work, is remote monitoring and virtual consultation and virtual wards. So I'll talk a little bit about that towards the end of the presentation. It's worth pointing out as well, there was a huge amount of innovation just in moving to remote working. You know, I think we can all remember, you know, the days when starting a Zoom or Microsoft Teams meeting felt very alien and was very new. Now it's actually the norm, and we've probably gone the other way now, where people don't want to come back into offices anymore. But trying to support health and care staff to evolve working in that way and how to make use of these new technologies very, very quickly was a challenge in itself, and I think is a great success story also. We did quite a lot of work with care homes across Greater Manchester as well, right in the middle of the, you know, some of the darkest times of the pandemic, where care home staff were, you know, quite felt like on their own and didn't have connection into the digital infrastructure that the NHS tends to have. So we worked with an industry partner who we'd done some proof of value work with before to develop a COVID tracker tool that carers in care homes would be able to use to monitor patient symptoms, resident symptoms, and direct that data to the clinical teams to monitor patients. And then it turned out that we kind of evolved the tool further to manage the impact and the spread of COVID in care homes as well. So that's just a great example of where we'd already had a relationship with an industry partner, really needed to support the health and care system to step up to this challenge, and we're able to deploy that at scale across GM. And we're now looking at the kind of third phase iteration of that programme of how we can expand that even further to support care homes. So some great examples there. And I don't think we necessarily would have been able to do some of that had the pandemic not been around. I think some of that would have taken years to get off the ground. So what we found during the pandemic was, because the priorities and the focus were sort of mandated, if you like, and money was made available, we were able to get traction really quickly from partners to be able to develop these solutions, put them into practice, and then deploy them at scale. I think we found that much harder before those that structure and focus was in place. So they're interesting thoughts to think about as the NHS continues to face incredible pressures across the system. So just to go to talk about the GM Care Record a little bit. Now, people might have heard, you know, about the Care Record many times. We talk about this quite a lot, but it's a great example of a programme that has really evolved and developed over the last few years, particularly enabled by responding to the pandemic. So the GM Care Record, just so people know, is the name we give to our shared care record across the Greater Manchester system. Prior to the pandemic, it had been around for quite a few years in some localities, but each of the 10 localities of Greater Manchester had deployed it locally. There was quite a lot of variation in how it was being used. There wasn't a kind of integrated shared product roadmap for how it was going to be developed into the future. Funding flows were all separate. And we kind of put a proposal together where we felt providing clinicians across Greater Manchester with access to vital patient information during the midst of a pandemic was a major priority, and we got the support from the system partners to do that. So the short story is, over the kind of first 18 months of the pandemic, we worked with all the data controllers and partners across the system to open up data feeds, open up access, and get data flowing directly to support vital patient care. And we've got some fantastic success stories of where, you know, particularly secondary care clinicians are saying it's been a game changer to be able to access the record and just see what medications think. These are the things patients think the NHS has been able to do for some time, and of course it's not. So it's fantastic that we've been able to do that, and that was enabled in part by the national coping notice, and we're just working through what life looks like when the coping notice finally does expire, which will be sometime this year, so we can carry on all of that good work. We've now developed the care record in these kind of 3 areas as well. So supporting remote monitoring in different care pathways, and supporting data sharing, pathway transformation and research initiatives. I'll talk a bit more about this as we go. And then it's also got a really powerful population health and analytics platform within it. And we're kind of looking at how we use that to support service development and transformation across the system over the next year. Okay, so just to give you a flavour of what life was like with the care record before the pandemic, and how the response to the pandemic has helped us to really transform that. It's gone from being a shared cared record used incrementally in some localities to now being a major clinical and digital asset across the whole GM system. It's used increasingly by a range of different health and care staff each and every day, and that continues to increase, and we're working with the system to increase that. We've got a huge pipeline now of really promising research studies using data from the GM care record, and we've been developing that in partnership with our colleagues at the University of Manchester, but really working closely with data controllers, IG officers, Caldecott guardians, all those sorts of people that work in the health and care system, to make sure that we bridge the gap between the world of academia and health and care. And that's been a really interesting process. And I know Niels in particular has been fully part of all of that journey with me as well. So lots to reflect on in that in itself. As I've said, we've gone from these 10 localities working in different ways to having a pan-GM city region approach, and the record now contains 3.1 million different records with 99% of coverage across the patch, and we are moving to a position where we will have data sharing agreements and joint controller arrangements for all data controllers across the system, all GP practices, health and social care partners, NHS providers, social care. As you can imagine, that is quite a big undertaking to work across the system to get all these partners lined up, and it's not easy as well, and we're kind of still working through that. But that's been supported by an extensive public and data controller awareness and insight campaign, and the overwhelming insight from the public is that they really support this, but want trust and confidence that their data is being managed appropriately. And we've got some fantastic data to report on the back of the public insight work to support why the care record is welcomed by our population. So that's been a really important exercise too. And these are just some examples of how we've then taken the care record and used it to develop new functionality, or provide enable transformation in care pathways, from oximetry at home through to heart failure, sharing notes with NWAS at the point of care, through to supporting the dementia and frailty care planning, particularly in care homes. So they're just some examples of the use cases that we've got coming through the GM care record pipeline. So if that was kind of what we've done for the last 2 years, and there's more of that to come, I think it's fair to say the problems that existed before the pandemic are more prevalent than ever and still stand. So, an increasingly aging population. We have huge pockets of that in Greater Manchester with comorbid diseases and increasing incidence of disease caused by poor lifestyle factors. But we also recognise the impact of inequalities in all of this, and there's more understanding to be done about the exact impact of the pandemic on some of our communities, and therefore what sort of transformation and innovation programmes do we need to develop in GM health and care to address some of the inequalities that our communities face. And I'm particularly interested in digital inclusion as part of that. So if people attended the event last time, I talked quite a bit about our approach to inclusive digital transformation, of how we move from a place of thinking of inclusion as something we've got to tackle, rather than folding inclusion into how we design and deliver digitally enabled healthcare services now and into the future. People will have heard about the formation of integrated care systems. So that is NHS national legislation, where the short story is CCGs will be merging into new organisations called integrated care organisations as part of an ICS. That's been going on for a while. It was going to come in from 1st of April onwards. That's been pushed through to July, but there are very clear requirements for digital transformation set out in the ICS national guidance. And this just gives you a bit of a flavour of what the requirements are under these 4 key headings. And it's fair to say that's probably the first time health and digital health and data has featured in this way in national strategic documents of what ICSs need to come. I've been around the NHS for a long time, and it's been really great to see how the NHS is recognising the transformational power of digital and data. So now at Health Innovation Manchester, we have identified these 4 key areas of focus. And this is how we are now grouping our activity into an integrated portfolio. So the first is adoption and spread of proven innovation at pace and scale. The second is using data science, pathway analysis and transformation to deliver improvements in health and care pathways. We want to look at how we work with industry and use assets like the GM Care Record to conduct more trials and real world studies, and recognising the issues around inequalities, particularly kind of made worse by the pandemic. How do we look at place-based activities to work with our local communities and harness the sort of transformative power of digital and data as part of that? And then just to give you a kind of live example of kind of how we're taking all of that learning from the pandemic response and kind of what the big priorities are for the NHS moving forward. Virtual wards, oximetry at home, NHS at home, virtual care, all these different terms are being used at the moment. But essentially, the NHS has recognised the opportunities that delivering virtual care provides when patients don't have to be in hospital. So there's a national NHS at home directive, and we at GM are developing a kind of GM NHS at home programme, and Health Innovation Manchester is supporting the system to do that. So it's multifaceted, it's very complex, it's kind of emerging every day. It's a multi-provider approach across all 10 localities, and there are 3 distinct services that are being delivered at the moment, which is oximetry monitoring at home, COVID virtual wards and COVID virtual hospital. We're also looking at the use of remote monitoring technologies across different pathways. So we're undertaking a kind of deep understanding phase at the moment to get to grips with what models and arrangements have been set up in localities, what technology products are being used, how efficient are they, what's the patient experience like, how much does it all cost, and we'll be developing a blueprint for how NHS at home could and should be taken forward across the system at scale, ready for winter next year. So lots to come on this. We're talking with lots of different colleagues across the system, including colleagues at the ARC, about how we do some real in-depth insight and research into understanding this area, because I think it's an area that's got huge potential for the NHS to grow, to strengthen and to learn from. So that gives you an idea of how we're taking a lot of that learning from the pandemic and putting it into practice in a whole new programme. And I'm sure there'll be opportunity to have a session on, tech-enabled care, virtual care at some point through these meetings. So that's kind of it from me. I will stop sharing my screen and see if we've got any comments or questions on any of that. I'll have a quick look in the chat. Lots of everyone introducing themselves, which is really good to see. Okay, hope that makes sense for everybody. Okay, so we are right on time, which is great, and we'll be hearing from you, Andy, next. I don't know if you've got slides, Andy, if you're just giving us a kind of verbal update, but we're just going to hear from you in the Alliance for 5 minutes or so. Okay, thanks for that, Laura. And I think great to see a real practical, tangible example of excellence within Greater Manchester. And I would love to be able to see that we could feature that slide deck on our connector platform. For those people who don't know me, my name's Andy Bleeden. My background goes back here some years. I can remember joining the first one of these ecosystems, goodness knows how many years ago, maybe 10, 11 years ago, with some of the people who are here too, when I used to work in Stockport. But now my job here is to talk to you about the European Connected Health Alliance, with an umbrella organisation of which the Greater Manchester ecosystem is one of. For those people who don't know who we are, we're a member organisation. Most of our members, of those 900 people or organisations that join us, are not-for-profits, public bodies, universities, hospitals, government organisations, etc. I'll put a link in the chat function in a second for you to join us. It's free for those members. We have some other members who join us who are small, medium, large companies, one of whom we're going to hear from today, which is coming up soon from Better, which is fantastic. But our job is to connect up all the dots within our different ecosystems, both within them and between them. People join us for a variety of reasons. You can see those in front of you. I'm not here to talk about membership today, though. I want to talk about linking up Greater Manchester with the rest of our network, okay? Because we're an organisation that's got over 70 ecosystems. The first one of which was there, baked in Manchester, with some of the people who are in the room today. The idea behind it's simple, and that's around matching need and solution. You can see some of the examples in what Laura's talked about there, which are fantastic examples within Manchester that are, I think, shining beacons for the rest of the ecosystem network that we've got. My question and takeaway from today is, looking around the audience today, who's missing out of that group of people that we bring together? Because we want to include all the stakeholders in health and social care, patient groups to companies, policymakers to funders. So who's missing? Because if there's people missing from that circle, you're missing a voice. And that's important, especially when you're developing things like the NHS at home, as we've seen in other countries as well. That focus on other countries is important. We've now got an ecosystem network of over 70 geographical ecosystems. Most of those, again, because of the pandemic, have joined us because they want to collaborate. And they want to collaborate with shining stars of health and social care, of which one of those is Manchester. So my work with the Great Manchester ecosystem now is to make sure that you can project excellence from Greater Manchester to those people who want to know about it in Finland or in Serbia or in Israel, or just recently opened up in Japan.
That network means a greater level of collaboration baked in across the EU, which is vital because of the political situation we're in now. We act as that connector between the UK and our ecosystems here and across Europe, but also globally. So this morning we were featuring our Australian and our Danish ecosystem together in what we've developed with our ecosystem network, which is a series of thematic innovation ecosystems. Now I'm looking to Manchester to step up to the plate for this one, because I think there's a healthy balance of information and best practice around health inequalities in Greater Manchester that would be really interesting to learn from and share with our other ecosystem networks and our members globally. But you'll see the areas we're covering there, ranging from continents through to dealing with the menopause in different countries, from digital health data to, as we're going to be doing later in next week, looking at substance misuse with our mental health thematic ecosystem. There's an opportunity there for members of the Greater Manchester ecosystem to feature there, as we're featuring from our members from Slovenia and our Better organisation that are going to be featured today. So look upon this as an open invitation. I'm not going to talk anymore because there's lots more best practice to come for you all to speak now. All I would do is this is a call for action, because each one of those ecosystems there are in addition to the geographic ecosystems. They're free to attend. They're free to feature best practice from Greater Manchester, whether it be Stockport or from the university there in Manchester yourselves, or from Healthy Innovation Manchester. So join us. For most of you, as I said, it's free. Let's get on with the show and see who we've got coming up next. I think it's Jack. Over to you.
Thank you, Andy. I'm just sharing screen. Are you seeing the screen okay?
Yeah, that's looking good, Jack.
Perfect. I'm off video as it's not quite timely, but I've been having issues with the internet. But glad you can all see my screen. So thank you for the opportunity to present today as well, of course. But so I'm Jack Williams, and what I wanted to do today is share some of our insights on digital innovation. I'm the UK client director for our One London account, and albeit we are supporting the Christie with their digital forms transformation in Manchester. Just wanted to touch on some of the work that we're doing across the One London region as well. And Laura, it was really good to hear, and there's some synergies to the great work they're doing with the GM Care record as well. So today I'll just provide a bit of an introduction to Better, and then I'll talk through the use case innovation. And of course, if you've got any questions, please feel free to shoot them at me. So at Better, we, and Andy, as you were saying, like the international landscape, and it's great to hear what Manchester are getting involved in there with different markets. We operate across 3 different continents and 16 markets, and we're supporting over 1,000 healthcare institutions. From a Better perspective, our key principles, and this is exactly what we're doing with the Christie in Manchester as well, but it's based on our open data platform and open standards. And essentially, there's a clinical data repository that sits alongside our platform. And this really separates the data layer between the citizen and applications. With that in mind, we can therefore ensure that data follows the citizen rather than being locked within an application. And within the platform itself, it's built modular with flexible architecture, and also has a low code approach, so we can rapidly assemble an IT portfolio. One thing, we've considering the industry itself and aligned with our approach. Rachel Dunscombe previously quoted that data is for life and not just for one system. And as you alluded to, Laura, with integrated care systems, my focus is particularly within that space. And we're now partnering with 8 of what will become 42 in England. What we've seen within the space, I'd say there's definitely been a shift in healthcare innovation because of the pandemic, where provision has been required to be further connected between those acute settings, communities and clinics, but also within people's homes as well. And my background actually is some years ago now was within public health and like a proactive preventative role around wellbeing. And when I'm looking into ICSs, it's definitely apparent that there's a significant and increased approach to proactive and preventative health and wellbeing interventions. And with that in mind, really encouraging patients to take more accountability for their own health. But there's also increased patient demands where patients really requiring a really convenient and personalised healthcare and plan. We've definitely seen then that innovation due to the pandemic, where the trusts or the ICSs that we're working with, they're definitely more receptive to embracing new models of care, rethinking their IT architecture. But that does, of course, come with its challenges, with existing often, in the past built for institutions rather than having the citizen in mind. So a little bit about the Better platform itself before I move into the use case, because hopefully it'll put it into context a little bit. But the Better platform really has got a vendor neutral data core, and we can integrate with existing and new IT infrastructure. There's the low code tools there to provide the ability to really accelerate design and rapidly assemble new digital solutions, whether that's integrating with your existing systems, better teams supporting with new developments, or your internal development teams building out those applications. And these applications are really designed to provide that personalized experience for both patients and clinicians alike. So what we're doing with One London, and again, Laura just touching on some of the areas you shared as well, but we're designing a shared care planning application, which will commence with an end-of-life solution. However, there is then a future opportunity to expand further use cases in the future. So these examples may include clinical pathways such as cancer, frailty, dementia, neurology, mental health, psychiatry, and heart failure as an example. But the solution's really designed to have that bi-directional exchange, single sign-on, and in-context launch to existing systems. And importantly, this is across primary, secondary, and community care across the 5 and the 10.5 million citizens in the London region. When it came to built this and designed it on the NHS 5 priorities, and we did this because information is often not shared, it's inaccurate and inaccessible. By creating that single source trusted information and then integrated that anytime, anywhere, and it's up to date and in real time. So putting that into context, you could have a GP within primary care writing into the plan and an ambulance worker accessing that same plan and with that read-write capability. The key features really include a variety of dynamic access capabilities, enables us to capture patient information to ensure the best possible outcomes for patients and clinicians alike, like I mentioned. This really ensures that information can be accurately used throughout the patient journey. And then that really does have a positive impact on health outcomes. It improves patient and clinician satisfaction, but also has an impact and decreases the cost of care. Some of the key considerations when designing the care solution, and it's due to actually go live this summer, but was really around the clinical design and governance, the data control and modelling that we had to undertake. And I can imagine this is similar in Greater Manchester as well, but really owning in on the communication and engagement strategy. So what we've done there is really been supported with champions networks across the different CCGs. We have care home settings, acute settings, primary care, and it's really been, I suppose, the success is coming from designing that vibrant engagement plan, identifying the different communication channels that we can identify people through, And one thing that I've always found really beneficial is gaining that senior level advocacy across different organisations, so they can promote the reasoning around the solution, but also encourage users to adopt that across the different care settings as well. Because we're working across so many different populations, we've had to build in different personalised training plans. So as I mentioned, we might have primary care, acute settings, community settings, where access to the solution will be completely different in those settings, so they require that personalised training. This is quite a heavy diagram, so I don't expect you to look into it in too much detail. But this is the system context diagram, and I'll try and not get too technical with it. But basically, the model is based on a central and open persistent data store, which applications can plug into, and we can read and write the data. So for care planning in London, the application is really built on top of this open data store using the better low-code tools. And then we have a drag and drop functionality. And importantly there, that the users of the solution are shown on the outside and represent all areas of the healthcare sector who have that vested interest in editing and updating a centralised patient care plan. So this includes the patient and the circle of care, but also things like the GP surgery, acute hospice, care homes, social care, community and mental health. The key asks in all of this for us were really to provide that seamless access for creating updating care plans. And this is achieved through a federated access model where clinicians can access the care plans through their native EPRs without having to log in with another set of credentials. And then another key ask for us here was really reducing that data, reducing data duplication and rekeying information. And we achieved this in a couple of different ways. So we did this by establishing that single source of truth that everyone has seamless access to, and really ensuring there's interoperability. So utilising existing information systems, which is captured in the EHRs, especially GP systems like EMIS Web and TPP System 1, to populate the care plans and push the info back into those systems using the open standards. So this real patient-centric data model will service additional care plans, so it's not just the end of life use case being served in the future. So hopefully that's been a useful overview of the project that we're working across the 5 ICSs in London. And like I say, we're spending the attention with the Christie and the Manchester, and we hopefully will learn more about what the fantastic things that you're up to in the region.
Thanks for that, Jack. Really helpful presentation. I don't know if you're able to put your camera on. We've just got kind of 10 minutes or so where we can do some Q&A session, if that's all right.
Yeah,
so you're hiding in the dark. Oh, there you
go. my internet wasn't great. I dropped off Laura. So
right, okay. Don't worry. I don't know if you can just stop sharing your screen, Jack. I think that's you, is it? There we go. So, Jack, was this, because I know a little bit about One London, I don't know if other colleagues on the call do. So did this originate as one of the LICRA exemplar areas? Yeah. So just so people on the call are aware, oh God, how many years ago is it now? I think it was about 3, maybe, must be 3 years ago. NHS England nationally awarded pots of money to, I think it was originally 5 exemplar regions to deliver a local health and care record exemplar programme, one of which was One London, one of which was in Greater Manchester actually. So it's interesting to just see the journey, because I kind of followed One London at one point when we were kind of deeply involved in the LICRA programme and kind of, not been as connected. And I know they did a huge amount of public and community engagement, didn't they, as part of the One London programme. How was that public insight influenced the better platform?
I'd say Influence to a large degree, I'd say, Laura, and not just with One London, but we're actually we're deploying the solution across Suffolk and North East Essex ICS as well. But I think it's been absolutely key to really get the viewpoints of the patient and the citizen who are actually utilising the solution. So as well as back office or clinician use, we've also integrating with the NHS app. And will there be a patient-facing application? So yeah, to your point, it's been played a massive part in gaining that feedback, from a user experience point of view, but throughout the whole design phase, really.
And from the perspective of the pandemic, how has that helped or hindered your progress and initiatives?
Honestly, so I'm quite new to the team at Better, and I'd not met my team for about 3 months since joining. But I think in today's day and age, it has been complex. It's not just like Better who's deploying the solution. We've actually utilised a number of different partners alongside that as well. We partner with Restart from an integration data migration point of view. CareIS and Zycare, who are based out in New Zealand, so there's a time difference challenge there, and then also Athos as a consultancy. But I think it's just precedent to having like strong project management to manage the program, and also having that trust and visibility with the partnering organisation. It is a highly complex program, and against tight timelines, and I think that the best thing in all of that has just been completely visible with one another, having the key accountabilities and a real in-depth and detailed project plan. So quite a long-winded response to your question.
No, it's really helpful.
I wouldn't say it's hindered. The reason why it may have hindered is due to clinical governance, really, and the input that we've needed from clinicians. Of course, they're swept off the feet at the best of times, especially now. So we've just got to ensure that whenever we're taking the clinicians' time, it's got to be on point, and we've got to have key asks to how we can support us, really.
Yeah, and I think that's exactly right. And what you said during your presentation and that about the sort of the importance of sort of how you communicate this out is really, I'm a comms person by trade, so I'm kind of biased in in that thinking. But I remember when we were working on the care record, the techies wanted us to go out talking about the tech, and I was like, no one's really that interested in the tech. They just want to know how it supports them with patient care, and that it's easy to access. And we could have an hour session just unpicking all of that. But I remember I used to kind of be saying, if you want to win the hearts and minds of staff, don't talk about the technology. Just talk about the benefits that it brings to patients. They don't really need to see the wiring that goes underneath it. So just get your perspective on that, unless we've got any other questions as well from the audience.
Go
for it, Jack. Yeah.
To add to that, Laura, so my background again is actually digital engagement from a proactive wellbeing point of view, and we deployed digital tech across. It was not healthcare institutions, mainly like insurance and financial. But you're exactly right, and it can be the best solution in the world, but if people aren't adopting it, it's absolutely useless. So what does that comms and engagement plan look like? And it can't be techie language, it's got to be clinician centric. You've got to understand it. Why is it going to improve the patient experience? Why is it going to make their jobs easier? And another thing that we're also seeing is actually looking at the outcomes to the program. So, how is it actually improving patient experience? How are we getting that feedback? What are the short? I don't know what's happening. There's a bit of feedback.
I think it's you. 1 sec. We'll get you back there, Jack. Yeah, try again, Jack.
But to encourage that ongoing engagement, we set out short, medium, and long-term KPIs and looking at specific metrics. So those metrics might be around like usability for the clinician. How is it making the job easier? Why are patients benefiting? Is the communication across the different MDT teams better for them? So what I'm trying to say there is, communications plan up front to encourage adoption, but keep that communication plan rolling. And a good way to do that is to celebrate the success of what you're achieving with the solution or the program itself as well.
Super. Thanks so much, Jack, and thanks for a great presentation and answering all of our questions. So now we are going to be joined by John Ainsworth. Hi, John. And you're going to be taking us through the eLab Health Data Science Workbench. And then after that, I'll hand over to my colleague, Peter, who'll go through the rest of the session with you all. So thank you.
Okay, thanks very much, Laura. Hopefully you can now see my slides. So this is also a bit like a trip down memory lane for me, like it is for Andy. And I just checked back through my emails, and I found one, Andy, inviting you to an mHealth ecosystem from Jan 2012. So there's probably a 10-year anniversary event in there somewhere.
It's still using the same slides, John, I see as well.
Anyway, sorry, for those who don't know me, I'm John Ainsworth. I'm Professor of Health Informatics here at the University of Manchester. And I'm going to talk today about a project that's been running for some time, actually, in various different guises, which is the eLab, Electronic Laboratory, Health Data Science Workbench, which I've developed in conjunction with my colleague, Dr. Philip Cooch, who's really the main technical lead on this. So I'm going to start by just covering what is a TRE. It's a phrase you hear a lot these days, and stands for Trusted Research Environment. And here's HDR UK's take on what a TRE is and why they're important. But they're essentially platforms for reusing healthcare data. And they do so in a way that's safe. So HDR UK call out safe people, safe projects, safe settings, safe data and safe outputs. And they're really a mechanism for enable us to make better use of healthcare data. And so the eLab project actually fits into the category of a TRE, although when we started developing it, the TRE nomenclature wasn't actually in existence at that point. One of the things that we wanted to overcome in developing the eLab was something that's known as hidden technical debt. So this is an example of hidden technical debt from Scully's paper, where they're looking at hidden technical debt in machine learning systems. And basically the principle behind hidden technical debt is that when we develop something, whether it's a machine learning algorithm, a piece of software, sometimes we take shortcuts for short-term gain, which ultimately, if the thing is going to have a lifetime, will need to be repaid because interest accrues on that technical debt. And so actually, short-term expedience costs in the long term is really the concept behind hidden technical debt. And you see in Scully's example here, you see there's a very small box in the middle entitled ML code, machine learning code, the bit that people think is really important about machine learning. But actually, the much bigger boxes that sit around this and turning it into a long-lived system are much bigger, much complicated, and take up much more resource. And so we said, well, actually, hidden technical debt also applies to health data science. Actually, there's a whole lot of work you do in terms of data preparation. There's a whole lot of work you do in developing analysis scripts. There's a whole load of work you do in formatting and presenting the results that actually can get picked up and reused. A really good example of this is around things like code lists. So if you're analysing coded data, say from primary care, and you want to find other people with diabetes, well, actually, there's a code list to do that, and somebody's put effort and time into that. Why not pick them up? Why not reuse them and share them as that was one of the key things that we wanted to address with the eLab. So through a number of different workshops, I think this is that slide actually, yes I have. So our motivation really was to enable open, transparent and reproducible health data science at scale. And our goal was to develop a health data science workbench that reduces duplication and minimises that technical debt. So the history of the eLab, obviously it's been created in an academic setting initially, and funding has been won through various different grant applications. And so we have over the years balanced the need to deliver infrastructure for those different specific research projects with creating a core technology platform. And we have had sources of funding from a wide range of places, from the Medical Research Council, from the EU Horizon Programme, from the US National Institute of Health. So we've actually deployed this in projects across the UK, across Europe, and across the United States as well. Very early on, we sat down with the various stakeholders and tried to work out actually what the core design goals were going to be for the eLab platform. And we identified 10. The first of these actually turned out to be one of the most important: reuse of core health data science tooling. And the insight here was actually there are lots of good tools out there, such as R or Python, that people want to reuse in a platform. They don't want to learn something else. So we need to bring in the best of breed tooling. Obviously, due to the nature of the data we're applying this to, a system needs to be secure by design. That means not only in terms of access controls, but also in terms of logging. We also wanted to achieve FAIR data. So for those of you who don't know the acronym, FAIR stands for findable, accessible, interoperable, and reusable data. And this very much belongs in the movement of sharing and open data and transparent science. Designed for reuse, so that key thing about removing the technical debt, being able to share digital assets between projects. We needed to support collaborative virtual teams. So way before the pandemic, we were dealing with research collaborations that spanned not only different institutions, but different countries as well, that needed a place to come and collaborate on their science and have an interaction and a dialogue. We wanted it to be simple to deploy, to maintain, and to use. We didn't want to incur an additional burden that meant that actually you build something that's just so complicated, people will not pick it up, people will not use it. And we wanted it to be extensible and configurable, so it can be customized to somebody else's local environment. We also thought as well that actually there is an interplay here between research and education, and that actually a platform that's useful for research should also be a platform that's useful for education, because people learn from those doing the research. And if we're creating digital assets, digital artifacts in such a platform, let's make them available, make them usable for education. And finally, I think this is finally, I got to number 10, it needs to be scalable from one individual to global teams. So actually, the way we design the system architecture to enabling that scaling is actually really important over that. I think that's 9, so that must be 10. And we wanted it to make it accessible. So actually, we wanted to deliver this into the wider health research community, but actually also beyond that, into analysts in the NHS and other healthcare organisations. So actually moving out from just the academic sphere. So this is the eLab architecture. I'm actually not going to talk through the picture in the slide, but I'll just give you a couple of highlights. So what we've actually done with the eLab is we've actually taken the best in class open source software components. We've actually integrated and bundled them together into an easily deployable platform. So the eLab architecture is container-based. It actually uses Docker and Docker Swarm that enables us to scale. And we've actually integrated all those things together into a single package so that it can be very rapidly deployed, almost at the click of a button, either into a cloud environment or an on-premise environment. And so we like to think of it as almost as a TRE in a box, in that actually this gives you everything you need to do to create a trusted research environment. You just need to deploy it on top of the data on your hosting environment. And that was one of the key goals for us, because that actually satisfies 5 of our key design goals. And the way we make it scalable is by taking advantage of the containerization using Docker and the Swarm technology that lets us scale out the user-facing bit of the platform, which is the intensive part of it. And so actually, we do achieve that goal of scaling from just one individual to global teams. So the front end of what the platform, what the users see, is basically a web-based platform that is delivered on a project basis and entirely configurable, or how you configure your team, how you configure your project, what you see in there, what widgets you put into the lab front end, what dashboard features are in there. We also provide as well document management interface. So this lets teams share and collaborate on documents. We've just most recently, for one of our projects, added a paper development workflow. So actually people come here, they collaborate on writing their academic papers, and of course they have ready access to the data and the results. So actually you manage to do the whole workflow in one system. To support things like FAIR, we've also built in data catalog to this, so actually people can search through the data sets that are loaded and find the data and the variables of interest. This, of course, also promotes reuse, but it also has a purpose as well, in that actually it enables education users to actually browse through the data and get an understanding of the shape of the data and see how the data looks. And then probably one of the nicest features that we've done with eLab is we've actually embedded Jupyter notebooks in here. And if you're not familiar with what a Jupyter notebook is, it's an interactive coding environment that lets you develop and run bits of code or develop entire scripts. And the Jupyter environment that we've deployed connects directly into the data sets in the back end. So you have access for everyone in the project, access to the data, access to the Jupyter notebooks, and you can share the Jupyter notebooks. And the Jupyter notebooks achieve that design goal of reusing core health data science tooling, because they support R, they support Python, they support Julia. And the notebooks themselves become a reusable and a shareable part of the platform. So you can actually transfer those to other members of projects, or you can actually export them and share them with other people as well, because their code, there's no data attached to them. One final thing that we've also done in terms of promoting reuse is we've implemented a standard called the research object that was originally developed by one of my colleagues in the university, Professor Boyle, but has now been adopted very widely at scale across the EU, particularly across the European Open Science Cloud. And it's the research object format, and it's a mechanism for capturing and archiving the outputs of digital research, including health data science. although we started off as a research platform, over the last couple of years, and particularly actually I think driven by COVID-19, we've seen a lot more deployment and usage of the eLab for education, mostly within inside the University of Manchester, but we've used it to support our postgraduate taught programs in health data science and health informatics, because it enables us to offer a consistent experience to the students, enables what we term social learning, where actually we can bring different students together, create teams to work on problems together. It gives us good flexibility, and of course the usability brought about through the Juniper notebooks makes it an ideal platform for that kind of education. And as I said, the pandemic was a real driver of this, because we had to find a way of delivering what we would normally deliver in a lab, actually online in a collaborative space. And of course, that's exactly what the eLab was designed for. We have also moved beyond the academic setting. So we did a pilot with the GM Health and Social Care Partnership about deploying the eLab into the Analytic Data Services platform, and it's run by Matt Hennessy and his team in the Health and Social Care Partnership. And there's a couple of extra features there of the eLab that I have not mentioned that they were really interested in, which was the FHIR database that's embedded within a terminology service. Well, actually, one of the things they were most interested in was, again, the ability to have the Jupyter notebooks delivered by the Jupyter Hub. And we did a pilot with those guys. So here's just one example of some of the stuff they've done, looking at the prescribing of dementia medication across GM. So here we're demonstrating the ability to actually deploy eLab into their environment, which was a Snowflake database, rapidly adapting it, and then giving them the tools that they need to actually be able to analyze that data, visualize it, as you can see there. This has then moved on a little bit most recently. So towards the back end of last year, we were awarded some funding from NHSX as part of their TRE program. What we said we would do within that was to fully embed the eLab platform into the GM Analytic Data Services platform. And you can see there in the top right a figure of how this proposed infrastructure will work out. I'm not going to go through that in any kind of detail, but suffice to say, it's a further integration of data assets across the GM system. And the eLab will be one of the key tools for accessing that for a research or a population health management analytic perspective. And as part of this program, so NHSX, or probably not supposed to say NHSX anymore, but NHSX have an emerging TRE standard, which identifies many features that are already supporting eLab, but adds a few more in that we'll need to achieve compliance with. And then the other aspect of this project is for us to develop a reproducible TRE blueprint that can be shared and disseminated more widely across the emerging integrated care systems, because the goal for all integrated care systems is to build a data infrastructure like this to provide insights into population health and the ability to drive research from it. So that's pretty much where I've got to. If you follow that QR code, it will take you to a further page describing the eLab, particularly around how we've used it for education. One of the goals that I don't think we've fully quite met yet is the goal of being available for use by the wider health research community. And to help us achieve that goal, our aim is to deliver the eLab platform as open source software and that will be one of our next steps. And with that, I would like to say thank you everybody for listening, and I'm happy to take any questions if there are any.
Excellent. Thank you ever so much, John. It's Peter Richards here. So Laura's had to leave us, unfortunately, so I'll be taking us through the rest of the session. So I work alongside Laura at Health Innovation Manchester. Just a very quick one from me, John. There's no questions in the chat at this moment, but again, sort of focusing on the pandemic, I guess, going back to the sort of form, how long ago was the sort of, this project and sort of initiated, and then again just the impact of the pandemic on your work and its acceleration, really. That'd just be interested to revisit that, if you don't mind.
Yes, so in terms of conceptualizing the eLab, that's almost as old as the ecosystem itself, if not older actually. Sorry, I seem to have got muted there.
Oh yeah, sorry about that. Yeah, okay.
So I don't know when I was muted, but anyway, it's been going for some time in terms of a concept, more than a decade. Probably around about 2010 was the first publication. It's been through a number of different software iterations as well. So this is probably generation 3, with all the containerization and the use of Docker. We've worked, as I said, mostly with Research Council funding, EU funding, NIH funding, and the pilot with the Health and Social Care Partnership predates the pandemic, but I think the pandemic has actually really accelerated the thinking around the NHS and what the need for TREs is, and obviously the eLab fits directly into that box of TREs. And so I think the pandemic has accelerated what we're doing, because the need to actually access this kind of data in a safe and a secure way, providing that collaboration, it has clearly been demonstrated.
Excellent. Yeah, well, thank you, John. That's really helpful to understand that. And again, the sort of, a lot of the projects that we talked about from a sort of direct care point of view earlier along with Laura's presentation is a lot of this work was planned, but it's just the pandemic, as unfortunate as the situation was, has the need for this innovation and the acceleration of these projects from both a direct care point of view, but also from an analytics and data science point of view is clear as well. But thank you ever so much for joining us, John. But at this stage, we're going to move on because it's 2:10, and I'd like to sort of introduce one of our academic colleagues. This is Ian Hall, also from the University of Manchester. So Ian, would you like to share your screen and introduce your project?
Yes, yeah, thank you everyone, and thank you, Richard. I'll just share. There we go. So hopefully everyone can see that. So yeah, welcome everyone, and thank you for having me along. So I'm going to talk a little bit about kind of exactly what I have been doing over the last 2 years, I guess, is what the pandemic has caused and sort of changed my workflow. So I'm going to focus on the social care analysis that we've been doing. This is very much from a central Department of Health kind of view. So this isn't about local care homes as such, and that sort of thing that we were that was mentioned earlier. And for those of you that don't know me, I used to work in what was Public Health England before joining Manchester in 2018. And during the swine flu pandemic of 2009, we were looking at outbreaks in enclosed societies then. And on the back of the swine flu, we did a lit review and we kind of knew it already, that smaller enclosed institutions have higher attack rates. So we always knew that care homes and prisons and other such settings had the potential for higher impacts of the disease outbreaks. And then we saw that in January, February 2020, we saw that on cruise ships. So the top left picture there is some analysis we did on the Diamond Princess outbreak. So, and then in February 2020, we were asked to look at how one might shield care homes when we saw the severity profile for from China for COVID, and we did some simulations for SPI-M. I'm a member of SPI-M. I'm a member of many of the SAGE subgroups, environmental modelling group as well, and that we sort of put in the advice there around shielding and how hard that might be. And then in April 2020, we started to see an increase in outbreaks in care homes, which I think is on the next slide. And we were starting to make advice around how bad that situation could get from sort of late March, early April. And that led us to convening a care home working group that was a subgroup of SPI-M at the time. And very quickly that got adopted by SAGE. And so I went from being kind of a SPI-M member, a modelling advisory group member, for those of you that aren't familiar with the language of SAGE subgroups, to being co-chair of a SAGE subgroup. And the early task for us on that working group was to look at data and the data needs and what data gaps there were. And it is quite shocking actually how poor the data around social care settings was then, and arguably sort of still is now, but it's better, and I'll sort of talk about that later on. But from a central point of view, I'm sure individual research projects and individuals sort of do have a good grasp of these things, but it's the reporting up for the Centre for surveillance purposes. And we also were able to start using some statistical analysis here, the generalized additive models, on the data that we were seeing about outbreaks, and start to look at where hotspots might be. And we saw in that early data hotspot in Manchester, Liverpool type area, as well as around Oxford. And that started to tell us that that there was a geographical clustering, potentially around staff movements, that it wasn't, the sort of staff were involved in this from a transmission point of view. And we thought this would be kind of useful for DPHs. I think that was sort of naive from our point of view back then. This was very early in the pandemic. I think events moved very quickly on, but you also see kind of an interest that it's not just there's spatial clustering, there's very different temporal dynamics as well. And that makes the analysis non-trivial. And we can see that if we then roll forward away from wave 1 to wave 2, there's very different regional patterns. The Northwest had sort of two humps. They had an early wild type kind of October, November wave 2 peak. And then alpha came through to be of a similar size, probably due to prior immunity. Whereas in the London and the Southeast, it was just an alpha surge. And so you see this sort of complex spatio-temporal pattern. And the two bottom panels there are an illustration of the data we were working with in sort of late spring, where you do see the gaps in the data. So we have the black line are the positive values are testing data. So negative is positive, black, red are positive tests. And then the negative are the deaths, and the purple are those associated with COVID. And so you can see in the left-hand care home that there were a large number of COVID-associated deaths, but there were fewer COVID-positive tests in this period. So there was really a problem with the testing and the surveillance, and deaths are a very lagged indicator. In the other care home there, the testing may have been slightly better, but actually the attribution of COVID as a cause of death was probably more weaker. And these are two different data. One, the positive values are from pillar 2 and pillar 1 testing data, and the blue and the purple, the negative values, are from CQC death notifications. So these aren't linked data sets yet. So this was sort of how we were trying to sort of interpret things. And you do see this underreporting in wave 1 because of the bias towards symptomatic testing. So that's a bit of a problem with some of the analysis. But things got better, and UKHSA, PHE as was, very quickly developed better algorithms for linking the data between the deaths and the cases. And so we're able to start looking at severity. And here we're looking at case fatality ratios from sort of linked deaths and the adult social care testing. And here you can see that I wouldn't trust any data before October 2020. So the fact that it suggests there's a 60% case fatality rate is purely because of an under ascertainment in cases. Through the summer in 2020, that lowering of severity is because they suddenly started PCR testing whole homes and finding historical cases, so historical infections rather than current infections. And then things start to stabilize around September, October, as mass testing becomes a regular thing. And then you see that there was a slight increase in the case fatality ratio due to alpha. And then vaccination kicks in and it stabilizes at about 13% or 16%, I said on the slide, but I think it was more like 13%. And then crucially, this is up to a couple of weeks ago, there was an additional decrease due to Omicron becoming the dominant variant. And PHE, UKHSA are now looking at this and changing this now to be an event-based, so allowing people to be reinfected. So we will go through a process of reanalysis of this in the next few weeks. We can also look at this spatially, and you can see, you can start to, I won't spend too much time on this slide, but you can see there's a regional pattern there, possibly with the Southwest not showing the same decrease in severity, because their outbreak up to the new year was probably more Delta and less Omicron than say London and the Northwest. So there is sort of a regional pattern and narrative that can be drawn out. So that's sort of the improvements in data, and data really has improved markedly. And I'll talk a little bit about infrastructure and trusted research environments later on. There's also been some serious policy questions that have come out. So this time last year, well, a little bit earlier, probably around January time last year, we were asked to look at vaccine impact, predict vaccine impact, and suggest what critical vaccine thresholds we would recommend. And that led to us doing some modelling in the of the care homes, and deriving this sort of threshold of 80% staff and 90% residents. And it's quite worrying as an academic when suddenly that you're advising there on that threshold and you actually see it be used by policy and become a policy. And I mean that I worry not because I think it's wrong, but because I think it's not necessarily how you would choose to implement that policy. It became a mandation policy, a requirement of work. That's not necessarily how I, as a liberal academic, would choose to implement the policy, but that's how the advice was taken on, and we have to be aware of that, I think. I think the other thing that's kind of interesting, another challenge that was put to us was whether we should allow visitors. There's a harm from having people isolated, especially older and frail people. And we work with Alex Thompson in the Centre for Health Economics in Manchester to look at the harms of isolation against the harms of disease. and really balance those two harms. And we were able to sort of show that there was probably an order of magnitude gain in allowing visitors and going back to some degree of normality of life. Both these examples of the whether to allow visitors and whether to vaccinate, or how far to vaccinate, both show kind of data challenges or gaps in the research evidence base that I think are worth reflecting on. The vaccine question could have been improved if we had good data on contact patterns within a care home. So forget about the sort of general surveillance. This is just fundamental kind of who meets whom. And NIHR have funded such a project. University of Leeds are leading that. So we will know that in the next few months. But yeah, there's a timescale difference between a well-funded, well-balanced research project and when we need to know the answer by. And here there was a research gap as well around understanding transient changes in well-being compared to the risk of an infection that may be transient but also could cause death, or both of them could cause death. So I think that there are these big gaps that are outside of the surveillance realm. Then the other thing that we looked at is the behavior, the testing strategies. So at the moment, or not at the moment, over the past few months, care home staff have been following testing 2 or 3 times a week with one of those is linked to a PCR. So you do LFD testing 2 or 3 times a week, and then once a week you do a PCR test linked to one of those LFDs, and that is likely to be effective at an individual level. But we then had to look at whether the LFD alone mechanism policy would be as effective and more frequent. So maybe a daily LFD test for staff. And it is, you're testing more frequently. So logic says that it has to be a better policy. But I think what is lost in that sort of logic is that is only better if you take the workforce with you and they adhere to it and engage in the intervention, and they trust the intervention. And so there's a thing about, there's a human behavioral aspect here to weigh up the benefits of testing. And if we're not careful, we could erode the effectiveness. There's also quite a big, one of the live tasks we have is looking at trying to evaluate the impact of these the impact of these interventions, so we can say whether they were cost effective, and that's also hard because of the lack of surveillance in wave 1. And then I appreciate I'm sort of looking through this probably at a fair pace, but hopefully I'm just trying to give sort of vignettes of things, and happy to discuss offline or later. I think the other thing we were trying to sort of make sense of is transmission within the care home. This comes back to the how we engage with data. So for a large part of the pandemic, we were receiving data files and then storing them locally on the Manchester system in our secure area, and running analysis. We have now the Department of Health invested heavily in a data infrastructure from a particular company that gave a wonderfully pretty visualization software package that you could create lovely plots of the current trends, but you couldn't add value with analysis because the underlying architecture didn't allow for R to be run on the back of that data. So you could visualize the data. It did kind of the contractual obligation, but it didn't allow any enhanced or sophisticated analysis. So we couldn't do anything predictive. We couldn't project how many cases there would be. we were having to rely on data transfers. So thankfully, we sort of pointed out that that was unhelpful, and DH analysts realized that themselves. They didn't really need us to point that out. And so they've migrated now to Edge, an Edge system that has virtual machines and sufficient computational resources. And so now we can start actually running our R scripts on a VM. And it means I'm now spending my life putting authenticator passwords and things in, but it is a better way of doing the analysis. And so now we can start to actually tease into, given the number of outbreaks that we've had reported, we can see how big those outbreaks are if they finished, and we can start to look at the average number of cases per outbreak. And here, the left-hand plot is an example of some of the of running the GAM as a sort of predictive model on the outbreak data, and then the right-hand plot there is showing how many cases we saw and you can see here the impact of vaccination, that you've gone from about 20 cases per outbreak in peak alpha in January 2020, down to about 5 per outbreak, and that's in line with what we think the vaccine effectiveness is, of 75% effective. So that is reassuring. Some of those outbreaks have not yet finished, and so we can't really judge what's exactly happening on the data for Omicron, and what impact that might have, or indeed what impact the booster campaign will have. But that's and you can see that the residents are about 50% of the total tests. So there's a sort of roughly 50-50 split between positive residents and positive staff and visitors. So we're now currently understanding that in terms of transmission dynamics to look at the cost effectiveness. So the other thing that we have managed to do, or the other thing that I've been looking at this week actually, so this is a graph that I only produced yesterday, and there's always a danger in putting sort of hot off the press graphs in presentations, but the blue line here at the top blue line is the community prevalence taken from the Community Infection Service, the ONS survey of positivity, scaled by the 600,000 roughly members of staff that you'd have in social care home settings. And then the black line is the number of outbreaks reported on a rolling 7-day sum. And all I've done is then divide it by 6 to get the dashed line, and 12 to get the dashed dot line. So this isn't really modeling, it's just scaling the curves. But it just shows that the outbreaks being reported are in line with the community prevalence, and so there is this. We need to work out why there would be that scaling factor. Obviously, the scaling factor in the second half makes more sense because it's there's a vaccine impact, but why it would be a 6th in the early part, I think we still need to do a little bit of head scratching around. But that's the sort of thing that we can improve and enhance. Now we've got the data linked, and we've also been able to link the data sets on Edge to sort of get an idea, given of going back a slide. Here, this is just per outbreak, mean number of people positive. We could also bring in the size of the care homes as per the CQC register to get a sense of how many people there are per bed, say, rather than per outbreak. So there's a few things we can do to look at this. Again, now we've got the data. So to finish, I do appreciate this is sort of potentially quite rapid and a little bit different from some of the other talks. So I've gone into more to some of the actual data than the data architecture. But yeah, as I say, this has been sort of consuming my life for the last 2 years. So it's sort of, worth discussing. I think early on we had very weak data. That's partly an artifact of the fact that there wasn't a demand for a sort of central surveillance hub. We have better data now, but we still have some key gaps. One of the reasons for collecting data is to use it, and by use it I mean evaluate interventions and do advanced analytics. It's hard to do the evaluating of interventions because we don't have the comparator wave 1 analysis because of the way these things were set up. One of the other big gaps we have is on home care or domiciliary care and other settings, and prisons I mentioned in passing. Prisons are kind of related here. We just don't. There is a fundamental gap on who is undergoing home care or is in a care home. One of my colleagues, Bruce Guthrie, on the social care working group, continuously reminds us that we don't actually know who is in a care home at the best of times. So these sorts of linked data are going to be critical moving forwards to get a better understanding of the at-risk denominator population. And also we do need, there's a focus on where residents are. I mean, is genuine and really important, but we don't actually know who works in a care home and how many people work in a care home often. And we did a bit of work with the Methodist Care Home Association, MHA, to look at some of their data, and obviously the providers know who's on their payroll. So maybe we do need to engage a bit more with the sector to understand some of this as we're thinking about the next steps and future. And I think, yeah, having now we always kind of knew this, but policy colleagues want an answer by the end of the week rather than 2 or 3 weeks later when you've had chance to think about it and formalize your research. So there is an issue there. But I will stop there and leave on the acknowledgements here. This is a huge amount of work by people in the modelling group at University of Manchester, but also in the sort of DHSE analytics team, social care working group, and the participants and members of the social care working group. And there's also the Juniper Consortium, which is a consortium of modellers. There is probably a follow-up talk that one of my colleagues, Thomas House, could give to this group if interesting, on the work we've been doing at Manchester Foundation Trust on the hospital forecasting side of things for bed capacity. And my Turing fellowship was renewed on the basis that I promised to try and do a bit more on sort of analysis to support social care. So yeah, this is a live thing that I'll be looking at in the next few years. But I'll stop there, Peter, and happy to take questions or.
Great. Okay. Well, thank you, Ian, for that presentation and also sharing bang up-to-date data as well. That's really appreciated. There's no questions in the chat at the moment. Just a couple of sort of questions, stroke observations for myself, if that's okay. Particularly the role of social care data. I mean, I've spent my life in the last couple of years very much, probably 90% of my time talking about health and care, health data as opposed to social care data. And you made that point that traditionally social care data has been poor and it's improving, but what would it take for that data to sort of be at the, to improve and to make your life a lot easier in terms of interpreting that data?
Yeah, that's a good question, because I think it needs a holistic rethink of kind of how the data is curated and collected. I mean, I think it's one of the reasons, well, it's probably a bit naive for me to say, but one of the reasons possibly that health data is more mature in its journey is because we've got the NHS and there's one organisation. That organisation isn't quite as uniform as that statement suggests, but there is a little bit more command and control, whereas the social care sector is a lot of private organisations that may have commercial reasons behind the sort of data sharing and things. So I think that's one particular challenge that certainly goes above my pay scale. But I think that's something. I think so. I think you have to bring the sector with you on the journey and show that. I think someone else mentioned possibly, or it's possibly on an earlier meeting. All the meetings tend to blur into one now. But I think about engagement and bringing people on the journey. So I think that's and showing that there's actually value, that we're not collecting data so we can bean count and just, we're actually adding value to it and saying something about either the impact of interventions or how many deaths there might be in the future, rather than giving a nice shiny plot of the data, what they already know. Yeah.
I understand. Okay, well, that's really interesting. Again, thank you for your time in this afternoon. I'm just conscious of time. I'm sorry to move on, but I'm just going to bring in Steve Boyle now, who's recently joined us at Health Innovation Manchester, and his particular sort of role around sort of digital primary care, and how sort of the pandemic has created the need for a digital a way of interacting with primary care digitally, but also what the challenges that's brought in and for the future of accessing primary care as well. So I'd like to introduce Steve Boyle, if you wouldn't mind joining us this afternoon.
Hi everybody, Steve Boyle here, not Erin Boyle, that's my daughter's name, but somehow it seems to have got all linked up with my profile. Just hang on. Can you see my whole deck there?
Yeah, if you could put it on sort of screen share, that'd be
that's on there. Okay, so I'm Steve Boyle. I'm a program manager with Health Innovation Manchester. I've been around healthcare and healthcare IT for a long time, and I'm a nurse by background. So anyway, so again, appreciate that we need context really. So just while I just put this slide up, just let me just talk about the context for primary care in relation to this event. Primary care was already under significant pressure before the pandemic struck. And obviously when the pandemic struck and we weren't quite sure what was going to happen, there was a worry that organisations like primary care would need to pivot quickly to being able to offer services digitally as much as possible. And that meant a sort of rapid procurements and rapid deployments of lots of different sorts of tools into primary care. Now, as we sort of come out of the pandemics or the various waves in the pandemic, we have noticed also that actually lots of the issues that were sort of dogging primary care before the pandemics, and then as we come out, have re-emerged, as well as an awful lot of rebound activity. So people have stayed away, and I want to end on a slide actually to do about that. So my program really is not just about driving forward digital as a panacea, if you like, about let's sort of have that revolution that banking and retail made in services, and let's just sort of get that moving in digital sort of approach into primary care working, is to actually just sort of tackle some of those underlying issues that are affecting primary care, and as well as try and lock in some of the gains that we've had from taking a digital first approach where we can. So I think where this program begins is with some NHS funding. So again, this is about actually providing funding into support programs like this, and a really clear idea just in the sort of top left of the screen here is actually being really clear what we're trying to do. So some of it is about actually simplifying and improving access for patients. Some of it is about actually how we create and support some of those operational efficiencies in primary care, because primary care being the gateway of how most of us access healthcare services, and also the place where a lot of the continuity of your care is managed from, means that there's quite a lot of work that's unseen that faces primary care, as well as the things that are seen about when we come to try and access services. So something that actually makes a difference to that sort of workflow, generally improves access, and actually starts to think about primary care is something that works at scale, if you like. So what we're looking there to do is start to think about primary care working mutually in and around not just single practices, but how practices come together in primary care networks, and how those primary care networks can share those additional roles that we're hearing about as well. And I wanted also just to again echo just some of the things that Laura talked about earlier, and a couple of others have picked up, is actually what we wanted to do is explicitly ensure that digital first around primary care was not something that by accident or by unintended consequence created any further issues around exclusion to those hard to reach groups, or people who find it difficult already to access primary care for lots and lots of different reasons: cultural reasons, economic reasons, and the many other reasons why people are excluded. So actually what we wanted to do is make sure that in this program that this was an explicit part of what we did. Now, as we've sort of come out of the pandemic and working with primary care, we haven't just sort of made assumptions about what we've done here. We've made a deliberate opportunity here to really refocus in where's primary care right now. So we undertook a fairly novel approach, which we've called Understand, Reimagine and Implement. Now, what we've done here is to actually engage the population of providers of primary care across Greater Manchester. And again, not just taking a usual change approach of just approaching people who normally put their hand up to say, I'd like to get involved in a shiny new project. We've deliberately spent time and some of the funding to engage representative practices from across the GM footprint. So single-handers, double-handers, buildings where we've got multiple practices together, areas of Manchester where there are particular deprivation issues, cultural issues, which mean that people can't do it. So we can really get that understanding of what's going on. But we looked at multiple lenses as well. So this wasn't just about surveying and interviewing those individuals. We also did quite a lot of data analysis. So how have those digital systems that were rapidly deployed at the start of the pandemic, how actually have they been used? What's the workflow that surrounds them? How are they actually being leveraged? What effect are we seeing? What challenges are we seeing, etc.? And we'll come back to those in a moment. The other idea around Understand is, as well as engaging those who provide, as well as understanding the data that wraps around them and the digital architecture that it sits in, we also engaged very specifically the people who are expected to use primary care and actually to interface with those systems. So patients' views were things that we actively sought and canvassed. And I'll end with a really powerful bunch of slides, one slide, actually, not bunch of slides, at the end to talk about the challenges our patients face, because it ripples right back, not only into how we manage the workforce in primary care and how we manage the workflow in primary care, but actually some of the fundamental challenges we have in providing digital systems in primary care that we expect patients to use. So a real slap in the face, if you like, for those of us who've been in IT for a long time and think we're doing a great job, if you like. And I no slides, because Reimagine them was also from that understanding baseline. The understanding was actually then to start to ask those people, those who provide the systems, those who provide the services, the workflows, the patients, to think about what good looks like. What would that blueprint be like? What do we have to do to actually make and leverage and optimize digital first for primary care for Greater Manchester? Again, just making sure as well that we don't do anything unintended around making sure that we don't reinforce or entrench more exclusion as part of that. And then actually use a programmized approach to actually then implement those blueprints to allow change to happen at scale across Greater Manchester. And I'll come on to those things as well. So we first sit that in an overarching framework, which is not rocket science by any means, but actually we take time to frame the issues. We take time to think about the implementation and what we need to do. And I'll talk about some of that specifically, about how you design and understand the priorities for that. And then actually, what are you looking to change? What will this effort get you at the end? How will you know what you've done has made it better? Now, there are lots of baselines already in primary care to talk to us about where we are, how people are accessing services, what their satisfaction with those services are. So obviously we're looking where we can to sort of be measuring things that we already measure. So when we actually bring the groups of users, practice managers, GPs, people in the Rs rows, so these additional Rs roles that sit in primary care, when we engage digital leaders, when we engage people who provide digital services to primary care, and we sit them in a room with the idea of reimagining what we should do, we start to actually see that they're able to quite clearly articulate, and this slide here shows an articulation here of some of the things that they think would make a rapid difference to the uptake and the improvement of primary care, leveraging things digital. And we can see here that we sat the group down, we've used a matrix and asked them to think about, well, what are the things that we think actually would make a difference? And then spent some time with them thinking about the feasibility of those changes. What would the priority be? What should we lead with? What's going to be important for us to actually move forward with from a change perspective? Then when you sit down, you start to then be able to pull these sorts of 17 high impact changes into things that actually you can form programs around, and actually start to think about how you roll those out to start to make a difference. So starting at the top here, one of the real things that's missing from primary care, one of the things that really stops them is a lack of capability in actually being able to do things that we see in other parts of healthcare. And it's not particularly digital. It's about actually having that discretionary level of management, or that discretionary level of capability to help you understand, where are we now? How are we actually understanding and using these tools? What do we think we could optimize to? And then having people who can help you on that transformational journey and actually measuring and supporting and doing that. So this is about boots on the ground. So about half the funding from the program is actually creating a whole new networked workforce that we call digital first facilitators. So these are technically new roles in primary care to really help enable primary care and primary care networks have that additional bandwidth and additional support to help them undertake some of the work that they need to do. The next thing is how do you enable and equip those digital facilitators? So we're going to use some of the funding to actually bring together and curate and share quite a lot of the knowledge that actually is already out there. typically with any sort of change in the NHS, there are areas that do it well, there are areas that really, really struggle, not just in Greater Manchester, but across the UK. But what you have to be able to do is bring that information together, make it accessible, put it in a single place, and allow people like the digital facilitators to have access to things like how-to guides. A lot of the products that have been deployed across primary care as part of the pandemic work in different ways. So let's look at how other people are actually have got exemplar case studies, where they've got implementation guides, where they've got know-how, and where they can share that all together. And also as part of building that knowledge bank, that actually we train the digital facilitators who will be drawn from primary care, probably on a secondment or short-term basis, and actually train them in some of those skills like service transformation, understanding basic capacity demand, understanding how you map a process, and actually making sure that they've got the capabilities to do those things. The next phase is then to actually think about how services should be accessed. Because one of the things that we see, and I'll refer to in my very last slide, is actually the levels of fragmentation and the different ways in which access is actually managed across various parts of primary care. So what we have to be able to do is describe a blueprint based on best practices, based on effective workflow, triaging, and actually how we put those forward in a way where actually primary care can get a really good view about what they should be aiming for, what should be the standard that we're looking to do across that. One of the areas I want to really pick up and emphasize on is the impact of things like websites within primary care. They are significantly challenging. There is way too much fragmentation, and they're particularly ineffective, but they could be tremendously effective. But actually describing really clearly what a good standard and effective website should be, not just to what it looks like, but actually what the metadata and the data within it should be, to allow people to self-serve where they can, is actually really, really key. All of the things that you have to do always with any sort of program and anything like digital first is actually make sure that, like Blackpool Rock and the word Blackpool, is that communication and expectation are being clearly managed throughout of the whole program. Digital first program in Greater Manchester is not about beating people up. It's about communicating how people can get the best from digital care and how actually they can access it. And again, actually then making sure that some of that communication is also equally focused about how you help people who digital will never work for them, where a digital approach is something that actually is not going to be part of anything they can leverage as part of their care. So you have to be able to support alternative providers, access to other services, to actually ensure that actually they can engage with what they're doing.
Sorry to interrupt, Steve. We're just running towards the end of the meeting. It's really interesting. We've probably got another couple of minutes if you don't mind.
Okay, well, I'll just come back to this last slide. So one of the key things on this slide here, just to emphasize, if I do a minute on this slide, minute on the next, is actually looking at the workflow within practices. One of the ways we really think we can make a difference is actually lifting some of that high volume, low clinically important workflow off a day-to-day practices running and actually run that as a back office function at a PCN level. So that's one thing we want to actually prove, to give primary care the time to spend with its patients in helping them understand how they can access services. One of the key things we did is we reviewed what patients said about primary care. And I think I just want to leave you with these, because they're things you probably all know because we're all users of primary care. What patients said, just starting over to the left and working right, is they are really, really keen to understand and think things could be better. There is a real willingness from patients to actually adopt new ways to work and interact with healthcare. But the one thing they really want to have is the reassurance that that physical link, that human link with their provider of primary care is still there. We also know that when we adopt or we take patients digitally too quickly, that causes them anxiety, that actually they do struggle with some of that complexity. And also some of the media messages about primary care being really, really busy, actually patients heed those messages and stay away. We also know there's lots of digital fragmentation. We've all got an NHS app. We also might have an app that we need to sort of use to access our primary care at a practice level. We have to address that with the suppliers. We have to also be aware that there's lots of people who've got access to, who've got barriers to accessing those services. And I think as well, just to come back to the communication point, we have to realize as well that there really is low awareness across whatever we read and whatever we know about primary care and the digital options that we have. There really, really is that low awareness out there, not just with patients, but with those who provide the services. So thinking about how we communicate that much more widely is very key. I'd like to have spent more time on that, but I will stop right there. Thank you. Happy to take any quick questions.
That's brilliant. Thanks ever so much, Steve.
No worries.
It's a really important piece of work, and it's something which I was involved with very early on in the pandemic. And certainly, you know, I think it was Trafford within weeks went from about 30% of their practices offering digital appointments, etc., to about 90% of their practices offering digital appointments in a very rapid, short period of time. And you know, obviously that presents that was a great response at the time. However, long term, you know, like I said, you pointed out some of those issues there around accessibility, around knowledge of patients, and also making sure that those people who aren't digitally enabled still have access to the services that they need as well. Yeah. So at this point, Steve, there's actually no further questions at this moment. So I'm just going to close the meeting, and thanks to all the people attending today, and particularly the speakers, and also all at Digital Futures as well, who's helped pull this event together. So thank you to all, and the University of Manchester and the ECH Alliance as well. There will be a further ecosystem events sort of running quarterly throughout the year. So the next one, I think, is in April of this year. So please keep an eye out for those events coming up, and we look forward to seeing you then at those events. So thank you very much, and have a good afternoon, everyone. Bye-bye.